of MedTweetMY since in its inception. So, um, a brief sort of introduction about myself. I went to medical school at the Royal College of Surgeons in Ireland. I was a military doctor from 2007 to 2011. I was stationed in multiple action services points at locally and also overseas. After a career in the military, I started my career in academia, progressing towards a postgraduate degree, doctor in surgery with UKM, and I continued with subspecialty um, training with the Malaysian Board of Urology. And ultimately, after completing the exams, was awarded a fellowship of the Royal College of Physicians and Surgeons in Glasgow. Not completing at that, I continued on to be trained as a robotic pelvic uro-oncologist at the Queen Elizabeth University Hospital in Glasgow. At the moment, I am the consultant urologist and also senior lecturer in surgery at Faculty of Medicine UITM and also UITM Private Specialty Center. So here is a brief outline of what we're going to share today. We're going to talk about, firstly, introduction to renal stones, a little bit of history, some words that we particularly always use when we discuss kidney stones, a bit of epidemiology of kidney stones and classifications that can be used when we are discussing or referring or talking about kidney stones. Most importantly, what are the symptoms that are associated or are significantly can show that there is a kidney stone attack in progress. Moving on towards after that is some investigations that can be done either at a clinic level or what available imaging that we can organize for the patient if we are in a situation where we encounter a patient with kidney stones. Options for treatment. The last one is issues. Issues is mostly questions and answers at the end. I'm happy to take live questions and answers, and hopefully together we can learn a little bit about renal stones or genitourinary stones for the betterment of our care for the patient. So let's continue on with a bit of introduction. I like to play with words. I like to learn history of words. So when I was preparing this slide, I figured I researched on what calculi means, because we always say renal calculi, ureteric calculi, bladder calculi. So essentially, calculi is taken from a Latin word which means small pebbles. So maybe it is a descriptive thing at that age when the people were describing pebbles or when they found stones that have passed out from humans, they described it as calculi. And then further on, we have the term urolithiasis or nephrolithiasis that we oftentimes hear and read about in the textbooks and also in academic journals. So essentially, lithiasis means to suffer from stones or from calculi. So it is also a Latin word. So stones in the genitourinary tract has been in the human race since we existed. And interestingly, first literary quotations about stone disease was found in between the years 3200 and also 1200 BC in Mesopotamia. Also in the early 1900s, when they were looking at mummies in the ancient Egypt, which was estimated to be aged around 4,000 to 5,000 years, they found that they also found bladder stones. So as long as human civilization has occurred, we have been suffering from stones in the genitourinary tract. A good thing to highlight is that surgical treatment for stones, especially bladder stones, was innovated by Ibn Abbas al-Zahrawi at the year 930 to 1013 AD. He's from Cordova, and at that point, a pre-existing perineal approach to the treatment of bladder stones was perfected by himself, and he also introduced the usage of forceps to remove the stones. So as we get to modern times, innovations in optical technology resulted in the creation of endoscopic equipment for examination of the ureter in 1977. It is called the ureteroscope. And methods to break or fragment the stones was initially invented in 1954 and popularized 10 years after that. It is up until 1980s where we had a breakthrough in lithotripsy when the extracorporeal shockwave lithotripsy machine was introduced in 1980s and approved for usage by the FDA in 1984. So as you can see, with the disease, which has always been with humans since the beginning of time, technology has caught up and essentially progressively increased the utility of equipment that can be used to eliminate stones in humans. So epidemiology, we like to talk about local prevalence. We don't have a lot of papers that show the occurrence prevalence of genital urinary stones in Malaysia. However, generally we can quote that worldwide the prevalence ranges between 7 to 13% in North America, 5 to 9% in Europe, and 1 to 5% in Asia. The highest found prevalence was 20% in Saudi Arabia. That was quoted in one paper in the early 2000s. And then subsequently, we know from epidemiological studies, 30 to 80% stones pass spontaneously, thus will not require medical attention. And then we found from the studies that urolithiasis develops more frequently in individuals with a family history of urolithiasis. So there is also a genetic link perhaps towards the development of kidney stones or genital urinary stones, and it is found at the rate of 16 to 37%. It has also been shown that when you have an episode of genital urinary stones, you are at an increased risk up to 50% to get a recurrence of the stone disease. So this is a good paper that was recently published by the urological group in Sarawak, which looked at prevalence. Because we don't have any nationwide papers. To be honest, the last nationwide sort of quoted paper for kidney stones prevalence and epidemiology was in the 1990s, and it is a good breath of fresh air for the Sarawak cohort to publish this paper, and it is a quite interesting paper, and they were looking at how the stone prevalence in Sarawak and risk factors associated such as dietary, BMI, and race, and also they confirmed it using ultrasound. So this paper is from BJUI Compass. If you can Google BJUI Compass, you can find that I'm also a consulting editor for that open access journal. It is open access, meaning that if you was interested to read any of the articles, you can access full articles from the website. And it is quite a fun journey to be consulting editor for that journal. And I implore the listeners and the viewers today to check it out at their website on Google. All right. So when we talk about epidemiology, the other thing that we oftentimes hear urologists quote is that the stone belt. So as you can see from the global map, Malaysia is in the stone belt of where we have 10 to 15% of stone occurrence. This is generally associated to our climate and also social conditions which are conducive to stone formation. In the red areas, the stones are oftentimes associated with poverty, however, and also the lifestyle that is associated with it. However, in Europe and the USA, the increased prevalence of stones are associated with affluence, which means that the environment of abundance of their diet, of their lifestyle has also increased the prevalence of stone disease. It is postulated, or it has been simulated by climate studies, that in a couple of decades, the stone belt will be moving upwards, northwards. So we might be out of it, we might not. So let's just see with the climate simulations that have been done. All right, so when you talk about genital urinary stones, there are many ways that we can classify the stones. generally, if you talk to medical students, they would like or they would oftentimes classify stones according to its character on X-ray. We can talk about radio opaque stones, radiolucent stones. So that is one of the ways to classify stones. And as you can see from my point on the slide, we can divide it also into size because what is the point of classification? But a way for us to manage or share different types of management of the disease. So if you classify stones according to the size and location, you will find that the treatment that is involved towards getting the stone, getting rid of the stone is different. The next type of classification that you might want to consider is a composition. As you know, that there are multiple compositions of stones that are exist in our in the world. We know that there are calcium stones, chloride stones, uric acid stones, and also stones that come from medication. For example, an antiretroviral medication, indenavir, can cause kidney stones as well. And we've talked about X-ray characteristics of opacity and lucency in classifying stones. So, following up to that, as you can see that this is a table of what are the types of stones that are radio-opaque. As you can see that there's calcium oxalate, dihydrate, monohydrate, and also phosphate. Essentially, these stones are the most common stones that occur in our country. Calcium stones are radio-opaque, thus it is visible on X-ray. Stones that are formed from uric acid and drug stones are most times radiolucent, and cystine stones as a result of a metabolic disease has poor radio opacity, so it oftentimes cannot be seen on an X-ray. So here we move on to the most important sort of like slide when we talk about genitourinary stones. We talk about the symptoms. Oftentimes, when you are working in a clinic or you're working in an emergency department, the patient will come to you with symptoms. The first symptom that they will oftentimes complain to you will be pain. So this is a very non-specific symptom. However, with further questioning, as with a good history can tell you can sort of like guess the pathology based on the history. Hence, that is why I cannot emphasize enough the importance of a good history when you talk to patients. So the pain that is typically associated with renal stones are pains that start at the loins or the side of the back or the upper quadrant of the abdomen. And oftentimes, if it is related to ureteric stones, it will radiate or will move to the inguinal or to the groin region. And as it moves down the ureter, the pain will go lower in the testis in men and also in the labia for the women. I will elaborate more on the pain characteristics in another slide. However, other symptoms that the patient might be complaining to you will be an abnormal urine color, which can be due to concentration of urine as a result of dehydration or crystallization. Some patients will also present to you with hematuria. Hematuria can be two types. One is visible or the other one is non-visible. And in patients with visible, they will oftentimes come to you as quickly as possible because it is a rather dramatic thing to happen when you pee out blood. And then the other symptoms that can be associated is when the patient comes to you with very vague abdominal pain and then with fever associated with nausea and vomiting. These are the symptoms that patients can present with when you are thinking of a pathology of genitourinary stone. So pain. Pain as a symptom, oftentimes as a result of stones will be sharp in nature. It is migratory, meaning that it will start at the area of the kidney, which is at the loins or the side of the back, and then will radiate to the groin. That is where the term loin to groin pain comes from. As you know, stones oftentimes develop develop in the kidney and then migrate downward or distally towards the ureter. Rarely stones form de novo in the ureter, and these stones, uh, because of the because of human anatomy, there are three areas of where the ureter is smaller in luminal capacity. It is at the pelvic-ureteric junction, is at the pelvic brim or as the ureter enters the pelvis, and it is also small or constricted at the vesico-ureteric junction where the ureter enters the bladder. So that is the areas that the stones most commonly will be stopped. So the pain, as I've mentioned earlier, will be at different sort of like areas. You can get testicular pain if you have the stone at the vesico-ureteric junction. You can have only loin pain if the stone is still at the pelvic-ureteric junction. And if it's in the ureter, it can be moving downwards towards the testes as well. So in ureteric or renal colic, the pain is phasic, meaning that it comes and goes. So this is also where the term colicky pain comes from, because the pain comes and goes. I like generally divide pain in colic or ureteric or renal colic into three clinical phases. The first one is the acute phase. In the acute phase, the patient will come to you with a complaint of pain, which is sharp and increasing in severity, and is not showing any signs of stopping. Sometimes they pause and increase their severity. This is the phase that is most painful or the most dramatic for the patient, and it is usually at onset between 1 to 2 hours. It will last 1 to 2 hours. It is also associated with not being able to sit in a static position. Patient needs to move and find a comfortable position. The patient is unable to sleep because of this pain. It is also oftentimes associated with nausea and vomiting. After 1 or 2 hours of onset of the acute phase, we move on to the constant phase. At this point, the pain is at its maximum. And when it is at its maximum, it has no signs that it will be reduced. It will just stay that way and often can last up to 1 to 4 hours. And it is at this point of where they feel that it is at their maximum pain level, they will seek medical attention. So they will either show up to their clinic at this point or go to the emergency department in severe pain. After that, it is the relief phase. So the relief phase is when the pain is reduced. So the patient at this point can sit still, able to sleep, and the relief phase often lasts for between 1.5 to 3 hours. So as it is basic, studies have shown that this process, these three clinical phases occurs between 3 to 18 hours. And most people will be thinking of not going to seek medical attention when it is in the relief phase, but rest assured, after a couple of hours, it will go back into acute and constant and relief. Uh, so when patients tell you that the pain has gone away, you rest assured, you can tell them that it will come back between 3 to 18 hours. So the character of the pain is as such. The patient will give a very descriptive history when you ask about the pain. Most importantly, note that the location of the pain is also important to determine the location of the stone. So we move on to the next thing that we can do when we see patients with renal ureteric colic: investigation. So at a clinic level, perhaps what we can organize is immediate analgesia, of which I will be talking about later. We can also start to investigate the patient with whatever modality that you might have at your center. But generally, as I tell my students, when we talk about investigations, we divide it into blood investigations, urine investigations, and also imaging investigations. So we go on to the first thing, which is blood. Blood there are multiple panels that you can take from the patient at this point. Full blood count to look at your white cells, to look at reactive thrombocytosis from the platelet, renal function if you have to look at any obstructive uropathy or an increase in the serum creatinine and urea. Also, if the patient or the episode is associated with nausea and vomiting, the patient might also have electrolyte imbalances. At the same time, serum calcium is a good marker to determine what type of stone this is, or as a target for us to give a preventive treatment later after the acute phase has been treated. Uric acid as well, because some stones can be uric acid stones. However, I must say that hyperuricemia is not exclusively related to stones. Some people who have uric acid stones have normal uric acid. And the next is the patient has other symptoms such as fever or pyuria, where they have pus in their urine. Children rago, it might be beneficial to do a C-reactive protein to monitor treatment when it is initiated. So the next is urinalysis. So urinalysis can be done at a hospital level or even a clinic level if it is available. Most times it is being sent to a private lab and you can get the results pretty rapidly. So we must understand that hematuria, either visible or non-visible, occurs in up to 85% of patients. So meaning to say that 15% of patients with stones might not have hematuria. So having a negative urinalysis does not mean you don't have stones. If you have the symptoms, it is worth it to go on to the barrage of investigations to find out whether there's stone or not. In the urinalysis, you look at erythrocytes, or what I was talking around just now, microscopic hematuria. It is defined as at least 5 red blood cells per high-powered field. And then oftentimes, colic or obstruction due to genital urinary stones is associated with urinary tract infections. At this point, the leukocytes will be positive. When you get more than 10 leukocytes per high power fields, it is indicative of the UTI, of which the patient might also have symptoms, might not. It might be beneficial to treat this urinary tract infection. The pH, when you look at the urinalysis, can also give us, when it is suggestive of an infection, can also tell us what type of organism that has caused the infection. Or if it's alkaline pH in the urine, it might be a sign of Proteus, Klebsiella, Pseudomonas infecting the urine. Another thing that might be beneficial if the pH is acidic, might be the stone is associated with uric acid. So it might be uric acid. So at a general practitioner's clinic, most times you can find the urine dipstick. So it's pretty self-explanatory. You get the patient to pee in a cup, and then you dip the testing strip into the urine, and you compare the color changes with the reference that is usually on the bottle of the strip. And as you can see, there are multiple panels that you can multiple types of information that you can get from urine dipstick, as such gravity, pH, the presence of leukocytes, blood, nitrate, ketone, bilirubin, proteins, and glucose. So, like I've mentioned about pH, leukocytes indicative of urinary tract infection, blood, and also nitrate can also tell us what type of organism that has caused this urinary tract infection. It is worth it to note that it's quite accurate, where a negative dipstick is oftentimes associated with up to 95% of negative microscopy. So if it's negative on dipsticks, no point. Probably you might not need to send it for urinalysis as a means to save, because it is pretty much well associated. The next in investigation will be imaging. When you talk about imaging, usually divided into X-ray, ultrasound, and CT. We're not going to talk about MRI because although it is an option, it is very rarely used, and we oftentimes stop at CT as means of investigating stones. So the first thing is in X-ray KUB. If you look at the picture on the slide, it is showing two things. Number one, it is showing a double J stent or a ureteric stent, which is used to unobstruct an obstructed kidney. And on the left side, there is also an opacity at the area of the renal fossa, which is probably can mean renal stone. So an X-ray KUB is a plain film. Uh, an X-ray KUB is different from an abdominal X-ray because it covers a lot more ground than an abdominal X-ray. It covers the lower rib cage until the whole pubic symphysis, the pelvic bone must be shown to say that this is an X-ray KUB. When you talk about X-ray KUB, it has low sensitivity and specificity to detect stones. However, a stone that is detectable on X-ray KUB might mean that the stone is amenable to fluoroscopic methods of detection when you are treating the stones with extracorporeal shockwave lithotripsy, perhaps. And an X-ray KUB is also an excellent way to follow up stones after intervention. So do not discount X-ray KUBs. It has its value in the management of urolithiasis. So we've shown that, you know, we've talked about this classification of stones. So essentially radio-opaque stones, calcium stones we can see on X-ray, and radiolucent stones such as uric acid and medication stones are unable to be visualized on an X-ray KUB. So a phlebolith is oftentimes confused with ureteric stones. You need to have a little bit of experience looking at X-rays to realize that this is not stone, it might be a phlebolith. Basically, a phlebolith is stone or calcification in the vein. The arrow points to a calcification. To an untrained eye, it might mean that this is a ureteric stone because that is where the ureter enters the bladder around that region. However, with practice and if you look at a lot of X-rays, you could find that there is a central lucency in that opacity, which means that this is probably of vascular origin. It is calcification in the vein. So be mindful of the existence of phlebolith. Sometimes it is phlebolith and it's not urinary or it's not ureteric or bladder. The next imaging modality that can be used or can be utilized in detecting or managing urolithiasis is the ultrasound. The ultrasound is pretty good in detecting kidney dilatation. However, when you want to trace the source of the obstruction that is causing the dilatation, as you go down distally towards the pelvis, the sensitivity of the ultrasound reduces. Obviously, because at that level, you have a lot of bowels moving about, and inside of the bowels, there's a lot of gas. So it obscures the view of any possible explanations for the obstruction. The ultrasound is usually used as a first line or a second line investigation at hospitals because patients come into the emergency department with renal or urinary colic. An X-ray did not show anything, so the next step would be an ultrasound. So the advantage of an ultrasound is that it can tell you that something is dilated, the kidney is dilated. So there must be something that is obstructing it. So you need to explore the situation by using more modern technologies of imaging. And at the same time, it can also detect radiolucent stones, which you can see on X-ray KUB. So the gold standard for investigation of urolithiasis will be a computed tomography scan or a CT scan, and a non-contrasted CT is of choice in the investigation of renal and ureteric stones. It has up to 95 to 100% sensitivity in detecting stones. So if it says that there is stone, it probably is a stone in the kidney or ureter. At the same time, a CT scan, although non-contrasted, is able to detect other pathologies which might be able to explain the symptoms that the patient is having. Another good advantage of the CT scan is that when you look at the images, there's also a Hounsfield unit which you can determine from the software of the CT scan, which will probably tell us what is the composition of the stone based on the density. Uric acid stones tend to be of lower Hounsfield unit, and calcium stones, or the harder the stones, the higher the Hounsfield unit. So this is a good way to predict the response to certain types of treatments, especially with extracorporeal shockwave, or if you are planning utilizing lithotripsy method. So the Hounsfield unit will tell us whether this stone is going to respond or not. I look at the participants, it's already 160 people dialing in to listen to me, talk about stones. Thank you very much for spending your Saturday night with us to learn and understand more about a condition that is quite common and easily treated by the right person or the right specialty. For the All right, so we move on to in pregnancy. It's worth to note that in pregnancy, the women can also get kidney stones, and oftentimes the symptoms are similar. However, your utilization of imaging is restricted because of the effects of radiation on the fetus. So ultrasound is without radiation. However, you have limitations of sensitivity. Nowadays, they have studied and looked at low dose CT scans that can be utilized in pregnancy. So this is an option in imaging modality to detect kidney stone. So when you speak about any imaging modalities, it is very important to note the sensitivity and the specificity of the modality. And as you can see from this table, CT scan has a very good sensitivity and specificity, as opposed to a KUB X-ray, which has 57% sensitivity and 76% specificity. So it is of lower, it is inferior when compared to a CT scan. And there's also radiation that is involved when you do this imaging for the patient. So a CT scan obviously has higher radiation, and X-ray also has radiation, but not as high as a CT. And as you can see that the low dose CT is only at 3 millisieverts as opposed to the regular CT, which is at 10. So this will guide us into which modality that we might want to utilize for the detection of kidney stones. So when we talk about treatment, the first line will be the acute management. What should be done in the first instance when you are facing the patient? Obviously, patient is in pain, you think about analgesia. Patient is vomiting, you think about hydration. And also, if you're at a clinic, should you refer this patient? That is a question that you must always have in your mind when dealing with patients with abdominal pain. For analgesia, it has been recommended in the European guidelines and American guidelines that we utilize non-steroidal anti-inflammatory drugs as the first line for pain management in colic, whether renal or ureteric, mostly ureteric. Intramuscular route is better as compared to intravenous or oral. And most times you can see people will use NSAID plus antispasmodics in the hope to reduce the pain. However, studies have shown that NSAID plus antispasmodics does not result in better pain control. So first thing is analgesia. NSAID is the choice. If the patient is contraindicated for NSAID, then you move on to opiate or maybe paracetamol as a analgesia option. So when to refer? When you're working at a clinic, when patients come to you with intractable pain, uh, which is not responding to your analgesia, you might want to think about referring. So that is the first indication of referral, when your analgesia is either oral or intramuscular are insufficient to manage the pain. If the patient has a transplanted kidney, you cannot manage this at a clinic level. It needs to be a specialist level care, because it is a precious kidney, and you do not want the kidney to fail as a result of the obstruction. If it is also associated with urinary tract infections, the patient come to you with a fever. When you examine the patient, the renal punch, so we always do it, is positive. This is a sign of infection. Hence, you will need to refer the patient to the hospital for more advanced methods of intervention. And also, if you're doing the blood test for the patient, and then when you review it, you see that there is an acute kidney injury going on, it is time to refer the patient to the hospital for specialist intervention. These are basically guidelines of which when to refer. The list is not until this level. It can be more, in the presence of fever, in the presence of malignancy, age, extremes of age, if the pain and dehydration is severe, requiring maintenance fluid, things like that, then you know that you need to refer the patient for specialist level care. So I can't move on if we can't talk about medical expulsion therapy. This is a highly controversial, sort of like still debatable topic in the management of ureteric stones. If you read the literature or based on your experience, if you're practicing long enough, you find that a lot of doctors will give alpha blockers, calcium channel inhibitors, or even PDE5 inhibitors for expelling stone from the urethra. Um, there has been multiple studies looking at each medication. However, I oftentimes refer to the European guidelines when you talk about things that are controversial. Just follow the guidelines. It has been said in the guidelines, the European Association of Urology, medical expulsion therapy using alpha blockers seems efficacious with patients with distal ureter stones. So if it's in the middle or proximal ureter, might not work. But if it's in the distal ureter and the size is more than 5 mm, then a medical expulsion therapy might be worth it, might be efficacious. However, you must also consider whether the patient is in intractable pain, whether the patient has acute kidney injury. So these situations probably not wise to utilize medical expulsion. You see that the stone size is more than 5 mm. Why it is documented, or the guidelines say the stones need to be more than 5 mm? It is because stones which are 4 mm and below, up to 80% of the time will pass spontaneously without any medication. So that's why they said that distal stones more than 5 mm need the medical expulsion therapy using alpha blockers can be beneficial. However, I must maintain that it is debatable. You can look at the evidence online and look at journals, and based on different people have different interpretations of the literature, and they will take what is based on their experience as well. So in my experience, my practice, I rarely use medical expulsion therapy. I will oftentimes try and actively treat the patient using more definitive methods of treatment. I reserve usage of alpha blockers, especially in I will only use them in distal stones especially in women as well. Because the study that showed it works, the analysis of it shows that it works in women. So and as I've said, if it is compounded with other symptoms of sepsis or intractable pain, then medical expulsion therapy might not be really suitable for the patient. So um, in cases that are the pain or the symptoms are well controlled, and in where the stone has been detected, however, it is not associated with any infection, the kidney function is normal, and it is well controlled with analgesia, you can attempt chemical dissolution. However, it does not work with all types of stones. Chemical dissolution works with uric acid stones, and the way you want to dissolve these stones is using urinary alkalinizers. So as a guide, if you are putting a patient on chemical dissolution, you want to look at the pH of the urine, and you will want to adjust the dosage of the urinary alkalinizers to a level that is 6.5 to 7. Anything more than 7.5 can be detrimental because it can cause calcium deposition in the kidney, causing formations of stones that cannot be dissolved. So this needs to be done, I would suggest, in a specialist setting. The usage of urinary alkalinizers will be monitored closely, and the way it is using the urine pH. There are many types of urinary alkalinizers. However, sodium bicarb is the preferred. There are multiple brands and flavors that you can use to alkalinize urine. So chemoprophylaxis is as a method to prevent recurrence of stones. And to utilize chemoprophylaxis, you need to know the type of the stone. It is not a one-size-fits-all approach when it comes to chemoprophylaxis. This is where we have certain limitations, because to understand or to know what type of stones that the patient has, we will need to fragment, evacuate the stone, and send the stone for analysis. So that service is not readily available in a lot of places in our country, but private laboratories have this service, and it is a paid service that we can offer the patient for stone analysis if the patient is a recurrent stone former, so that we can target chemoprophylaxis. But thiazide diuretics is used in calcium stone formers, and in patients with hyperuricemia and pure uric acid stones, allopurinol is also a chemoprophylaxis method that can be used. So after the stone has been managed acutely, meaning that it has been either fragmented surgically, we will want to counsel the patient to tell the patient of certain lifestyle adjustments that need to be done to prevent recurrence of stones. The first one is, of course, fluid intake. We would want all patients who have had stones which has been treated to increase their fluid intake to get to a level of 2.5 liters of urine in 24 hours. Simply because the more urine that is produced, the risk of crystallization or supersaturation of solids will be reduced, so you don't get a recurrence of stone. Other dietary advice that we can offer to the patients is to avoid excessive salt and protein intake, particularly for people who are trying to increase their muscle mass. Then protein intake might need to be monitored to prevent recurrence of stone. Citrate is a stone inhibitor, so you want to increase the level of citrate in the body. So it has been shown that increased intake of fruits and vegetables will increase citrate levels, hence inhibit stone formation. We talk about calcium stones, which is the most common type of stone. However, restricting calcium in your diet is not going to be beneficial, because when you take a low calcium diet, you will have calcium binding in your intestines. Will The capability of calcium binding in your intestines will reduce, so you will get a lot more oxalate absorption. So oxalate absorption then will increase the risk of calcium oxalate stones. So calcium in your diet should not be restricted more than normal. So you should not go a little bit extreme when you want to restrict calcium in your diet. So in general practice, so outside the hospital setting, oftentimes I encounter patients who have been put on or been prescribed, or they read from somewhere of a certain medication or herbal preparation called cystone, right? Cystone is, if I'm not mistaken, it is a herbal preparation, multi-herbal preparation, which is suggested to dissolve stones. However, if you look at the literature, this is a bit of an old literature from 2011. They looked at this stone and did not find any significant sort of like advantage when using cystone, either short term or long term. In fact, stone burden increased when they use cystone. So the literature does not support the use of cystone. However, there must, or you can, if you look hard enough, you will find some study that is supporting the usage of it. But generally, if you look at the guidelines, the European or American guidelines, there is no mention of herbal preparation in management of stone disease. And the other thing that we always find is Rowatenex we prescribe in the clinic setting. Rowatenex is a collection of essential oils, if I'm not mistaken, and it has been you know said that it can help with stone disease. So you can see patients buying it from the pharmacy and getting it from clinics in hope that that it can help with stones to prevent them from getting surgical management. However, this study, which is quite old, in 2010, they compared Roatenex and tamsulosin, an alpha blocker for medical expulsion therapy, and it's been shown that Roatenex is not efficacious in stone disease, as compared to tamsulosin, which has been proven to have an effect in terms of medical expulsion therapy. So these are the two medications or preparations that are readily available, and oftentimes patients will be asked to buy either by the doctor that is treating them or by the pharmacist that they have gone to. What my point from this talk is that those two, cystone and Novotinex, does not have a big body of evidence to support its usage. So you might want to reconsider your approach in managing patients with suspected stones and consider early referral to a specialist center. Um, Next is surgical management. Surgical management of um, urolithiasis. I will not go into details when it comes to surgical management, as I think that this talk would is not focused to urologists or people managing stones surgically. However, we can share some information of what can be done when with patients with kidney stones. The first thing with the problem with stones is that it will obstruct the kidney. So when you have an obstruction, you have a situation of high pressure in the kidney. So the first instance to resolve the pain or the acute kidney injury is to decompress the kidney. So the method that is oftentimes utilized by urologists is ureteric stent insertion. If we are unable to insert a ureteric stent insertion, there is a utility of nephrostomy, of which it is a direct injection percutaneously to the kidney to reduce the pressure. or to decompress the kidney, the obstructed kidney. So both modalities have similar intent, however, have its own advantages and disadvantages. Ureteric stent insertion will need to be inserted using a cystoscopic method, which means that you need to put a scope, cystoscope, through the urethra and into the bladder. All right. So we'll go on to the pictures later. Next option will be ESWL and extracorporeal shockwave lithotripsy. The utilization or generation of shockwave from a generator, which is focused to an area that is where the stone is, and this is an extracorporeal, meaning it's outside the body. Lithotripsy means the ability of the modality to fragment stone. So traditionally, before we detect the stone using X-ray, so fluoroscopy, so you detect the stone using X-ray, then you target the shockwave to that area. However, nowadays we can find the stone using ultrasound, so it will reduce the amount of radiation exposure for the patient. So that is also an option when you want to detect stones. The next surgical option for management of stones will be endoscopic lithotripsy. Endoscopic means the utilization of endoscopy, either ureteroscopy, ureteroscopy, cystoscopy, um, which generally means, you know, scopes into the bladder and ureter, and then proceeded with lithotripters. Whether there are multiple choices, but most times we use the laser to fragment the stone. More invasive method will be the percutaneous nephrolithotomy, the PCNL, of which a direct tract is created percutaneously to the kidney to insert a scope and to fragment larger stones in the kidney. So this is a picture of a ureteric stent. The blue coily plasticating is a ureteric stent. Oftentimes, what I tell my patients when I want to put ureteric stents in, I would describe it as a straw because it has a lumen, and it is inserted using cystoscopy, and the placement is guided using X-ray. Its function is to decompress the kidney by bypassing the area of obstruction. There are multiple sizes that are available for usage when it comes to ureteric stent, and there are multiple types of it. It can either be a short-term PTF polyurethane or a silicone stent, or a long-term metallic stent for obstruction caused by malignancy, so on and so forth. And this is a picture of how it lies in your kidney. As you can see, it bypasses whatever is obstructing the ureter by directly going into the kidney and bringing down the pressure in the kidney straight to the bladder. This is a ureteroscope. So this is a semi-rigid ureteroscope. It is not flexible, obviously. It is inserted through the urethra into the ureter, and then you can find the ureteric stone, and there are multiple working channels that can be utilized to insert guide wires or use lasers to fracture. Multiple sizes, meaning the size of the scope itself can be smaller or larger depending on whether it can enter the ureter or not. A more modern technique or technology expanding from the ureteroscope is a flexible ureteroscope. As the previous picture was showing a rigid ureteroscope, this is a flexible ureteroscope which has a deflecting mechanism which can access smaller cavities and at acute angles, at angles which are unable to be accessed by the rigid ureteroscope. Usually it is it has a deflecting mechanism. It has multiple working channels as well. Nowadays, a more advanced situation is where we get a disposable flexible ureteroscope. which is a single use, of which you use the robustness of usage can be increased. You can be a bit more kasar with it, and can treat stones, um, and you can throw it after that. And for every other patient, you use another set. But traditionally, the reusable scope is utilized. It has its advantages with a better image quality, traditionally mentioned. However, the newer disposable flexible microscopes have oftentimes similar image quality. But the robustness of usage is, of course, disposable wins, because if you startkan it, you can throw it away. So this is a short video of what it looks like inside the kidney using a flexible urethroskop. As you can see, that is a wire, because you need a guide wire to bring the scope in. There's also you need to use an access sheath to stabilize the size of the ureter and to reduce the pressure. And this is where we find kidney stones. And then after the stone is located, there is a kidney stone. You can either break the stone using laser, or you can reposition the stone to an area that is more easily accessible for you to be fragmented. So this is me trying to take the stone and reposition it to a better, easier area of the kidney for me to access the laser. The next is the invasive percutaneous nephrotomy, of which a direct track is created from the skin to the kidneys and dilated, so that you can introduce larger scope into the kidneys to manage larger stones. As you know, sizes of stones can differ. You can get even stones occupying the whole renal system, collecting system, and you will need a larger scope to deal with those stones, and a PCNL will allow that option. However, the technology nowadays also has made PCNL smaller. The scopes can be miniaturized, the access to the kidney is smaller, hence lesser complications, less pain, less bleeding. So you can either go with larger stones. Of course, traditional PCNL will be utilized. However, the option also exists for smaller stones in the kidney to be treated with PCNL. So that is my talk for today. Thank you very much. And I will take questions after this. So this is the QR code of which you can get my contact details to email me questions or to ask whatever you need. I will happily oblige and answer if I can. But nothing beats face-to-face consultation. All right, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Let's go to questions. I'll stop sharing now on my video so that everyone can see what I look like.
That's perfect. Thank you, Mr. Zainal Adwin, for the comprehensive overview. It is an overview, but at the same time comprehensive for a 1 hour talk. I would like to go through the questions, if that's okay, Mr. Zainal, yeah?
Yeah, sure, definitely.
Okay.
I'm
So the
happy
first
to.
question
Yeah.
From an anonymous attendee, how do we approach a case of persistent microscopic hematuria whereby X-ray and ultrasound KUB shows no renal stones?
All right. Well, a way to understand this is how you approach microscopic hematuria, because you must understand that microscopic hematuria does not mean stones. I mean, not just stones can cause microscopic hematuria. You need to really investigate microscopic hematuria thoroughly so that you can find the cause. You got to rule out malignancy firstly, because most times malignant lesions in the kidney or the collecting system can cause microscopic hematuria. So if the X-ray or the ultrasound does not show any stone, there are other things that you can consider. You can consider a contrasted CT scan, and also you need to survey the bladder as well by means of a cystoscope, which can be done using a flexible cystoscope. which is a quick procedure and does not require general anesthesia. So microscopic hematuria needs to be investigated thoroughly. The first thing that you need to rule out would be malignancy. Then you talk about stones and all that. Although, depending on the profile, if it's your younger patients, you might think of stones. However, the idea is to rule out malignancy before you move on to other dangerous pathologies, less dangerous. So if you to approach it, you need to continue investigating with a CT scan and a cystoscope.
Okay, perfect. The next question, can we give both thiazide and allopurinol as prophylaxis while waiting for stone analysis?
So this is a problem with chemoprophylaxis in a setting where we cannot understand or identify the composition of stones, because you can't just bang the patient with everything. So, well, thiazides are mostly used because the most common type stone is calcium. However, I would reserve the use of chemoprophylaxis until I get a good composition. So if the patient is a recurrent stone former, then I will present the option of getting the stone to be analyzed, and then we can put the patient on a regime of chemoprophylaxis. I will not give both medication as prophylaxis without a stone analysis.
All right, okay, we'll move on to the next question. Does Roatinex helps in treatment? Because in GPs, additional investigation besides UFIM would cost more to patients.
Yeah. So as I've mentioned in the slide from the talk just now about Roatinex, it has no significant evidence to support its usage. So as we strive to, try and practice medical evidence-based medicine, I think the evidence does not suggest the utility of Roatinex in treatment of stones. Additional investigations would cost more, definitely, yes, but there is a balance between risk and benefit of treatment. So you wouldn't want to do something that has been proven not to benefit the patient. So if it is an option, I leave the decision to the primary care physician, but the evidence does not point to advantage.
Right, okay, next question. Does all renal calculi cases need to be referred, or is there a specific size for further intervention, given the patient is asymptomatic and renal profile is normal?
All right. So, asymptomatic and normal renal profile, I would say as a first pass, it needs to be assessed with imaging that is sensitive and specific, a CT scan. So because there's a lot of information that you can get from the CT scan that can predict the outcome of the stone for the patient. It might not be asymptomatic now, we can predict whether this will cause problems for the patient later on. Also, a CT scan will tell us with the Hounsfield unit whether this is a uric acid stone or a calcium stone with higher Hounsfield unit, and we can aim for chemical dissolution using alkalinizers if it's suggestive for uric acid. I think all stones need to be referred first to finalize investigation. Once the investigation and the diagnosis has been established, all the parameters is known, size, location, kidney function, and all points to something that is not dangerous or with a potential to become a danger to the patient, then you probably, the specialist center should usually send it back to the general practitioner to be managed in terms of surveillance of changes in symptoms and so on.
Okay, the big question, what is the role of urine microscopy for microscopic hematuria and how to interpret it?
So microscopic hematuria is defined by the presence of 5 or more red blood cells. This definition depends on certain guidelines. Americans have a different definition. The Nephrology Association has a different definition. However, we generally follow more than 5 red blood cells per high-powered field. So that is the definition of a microscopic hematuria. So that is where the role of microscopy comes from. Because sometimes when you use dipstick only, you get a positive blood, which is a peroxidase reaction to the urine, which will in turn show the positive sign. It might not be blood. So the microscopy will specifically look at the red blood cells, the presence of it, and then we know that this is a real hematuria, as opposed to a possible false positive.
Perfect. All right. The last question that appears on the Q&A section. Besides NSAIDs, does IM Buscopan help to reduce the quality bin? I think it's been mentioned in your talk, but
Yeah.
finally, Mr. Zainal.
Yeah, so just now I told that, I mean, in the guidelines, there's some, I think three studies have shown that addition of antispasmodics to NSAID does not help the pain. It's more of a theoretical sort of thing. You want to reduce spasm, but in practice, in the real world, it does not help. So, like I said, practicing evidence-based medicine, we follow what the evidence says. So if it doesn't work, then probably it's unnecessary to expose patient to the side effects of antispasmodic, also to the additional cost that is required for it.
Awesome. Okay. All right. It's now 9:40. Just for just a quick announcement, we have actually shared the link to the attendance form. So please fill in your details accurately so that you can get your e-certificate and CPD points. Before we wrap up, actually, I'd like to ask Mr. Zainal, Mr. Zainal, just to check, by the way, is your camera working or is it on?
Yeah, it is working. It is. But I can't. Yeah, it says that the host has stopped it. So.
Oh, okay. All right.
Yeah, that's okay.
Yeah, all right. So I'd like to ask is if there's any conclusion, or take-home messages that we'd like to share with the participants tonight in the management of renal calculi.
I see that there's one last question about X-ray to determine the size, or we need to use CT scan. So X-ray can also be used to determine size. However, we have that question of radiolucency, radiopacity, and also the CT scan will give us further information such as renal dilatation. So that is why it is the gold standard for imaging. But an X-ray can be used as well to determine the size. So that is the last question that is on the Q&A box. Take home message from this talk is that do not discount microscopic hematuria with symptoms of loin to groin pain as being an infection, because most times the patients will come only after repeated bouts of these symptoms. So if you're in a GP clinic or you're in the primary care or in the community with patients that have microscopic hematuria with symptoms, please think of renal stones, because it might be obstructing and cause a renal loss. You might lose the kidney as a result. So, and refer the patient if you're not sure.
Absolutely, Mrs. Zainal. Actually, I've encountered some cases in which renal calculi has been neglected or not properly investigated, or of course issues with compliance for follow-up, etc., leading to renal failure. So it is an important condition to gain good understanding of, so that we can manage the patients properly to avoid further complications. Okay, I think we've gathered excellent response from the audience. Thank you for participating in tonight's CME. We've still got 100+ participants who still willing to stay and listen to you, Mrs. Zainal. So I think
exactly. I'm honored. Thank you very much.
100+ still at beyond 9:30. So I think people are really interested in this topic, and hopefully we can get another urology topic discussed in the next urology CME, if that's okay. We'll think of another topic, and fire away with your suggestions to MedTweetMY or with Mrs. Zainal. If you have any burning questions or suggestions for another topic, we welcome your opinion. And thank you as well for the participants who posted questions. And I'd like to remind again that the link for attendance and e-certificate is in the chat box. It is open until 10:30. Please do not share the link with other people outside of the CME. So I would like to thank you, Mr. Zainal, again for your time and for sharing your knowledge with everyone here. We hope to see you again. I think I just want to make sure that, okay, there's a couple of thank you as well in the Q&A box.
Lovely, yeah. Thank you very much. It was an honor for me to be talking today.
Yes, I think if it's not for the time, I'm sure there's a lot more questions, but we have to keep it short and sweet as usual. But inshallah, there will be more sessions in the future. So don't be disheartened. Just keep the email or contact our social media platforms to view for your views and opinions. Okay, Mrs. Zainal, we would like to wrap up. Thank you so much again, and thank you to all participants. I would like to end the session with Assalamualaikum warahmatullahi wabarakatuh and good evening. Thank you so much.
Thank you very much, everybody, for your time. Much appreciated.
Okay, I will open this Zoom until 10 p.m. Thank you. Dr. Zainal and Dr. Hafsah, if you wish to leave this room, you can leave this room. Thank you.
All right. Thank you. Bye.
Thanks, everyone.